Hey everyone, welcome to Taking the Pulse, a healthcare and life sciences video podcast. I am Heather Hoops Matthews here in the studio today with Maynard Nexon, healthcare attorney Matthew Roberts. Matthew, good to be with you.
Good to see you.
Joining us today is Dr. Marcus Blackstone. He's a doctor of medicine and leader at Secours Mercy Health, which is one of the nation's largest Catholic ministry and healthcare systems. Dr. Blackstone, thank you so much for taking the time to meet with us today.
Good afternoon. Thank you for the opportunity.
Now, you've worked in a variety of physician leadership positions within Secours and have grown into bigger and bigger leadership roles. Can you tell us a little bit about your current role right now, which is Acute Care Chief Medical Officer?
So sure, my current role is a system role where we're responsibility for the acute facilities in Secours Mercy Health. I actually have two partners. I have a chief care delivery officer and I have a counterpart that's an ambulatory chief medical officer. Between the three of us, anything clinical and patient care related actually falls under one of the three of us. So we all have dedicated areas that we're primarily responsible for, but there's a fair amount of overlap. And we try to look at things from the standpoint of not just on the hospital side, not just on the practice side, but make sure that there's a continuum between the two. And so that's really my role, is really a lot of it is support role for our markets who have accountability, for their geographical areas. But we work to really support the markets. Also, one of the big focuses is we've decentralized things, is to standardize what makes sense. And so when you look across, our markets, you look across our system, there's certain things that make sense to standardize to a point, keep it in mind that our markets are different. So that's the biggest part of my role, is really a lot of support to the 10 markets that we have.
Well, Dr. Blackstone, thanks again for doing this. And you manage thousands of physicians. And what are some of the challenges of managing physicians that are different specialties, different geographic markets, different payer mixes? Tell us a little bit about that challenge.
So it is a challenge. And then the other piece you added, Matthew, is that, in different markets, you have different percentage of employed versus affiliated. And so when you look at the different groups of physicians and you look at the different markets, they're different geographic. Some of them are, mainstream city. We have rural areas. And then to your point, there's a lot of different, payer mixes. And so we actually have a clinical leadership structure that has a chief clinical officer in each market. And that was my former role in Greenville before I moved into this role. And so that's our direct conduit in each market from a clinical perspective, is a chief clinical officer. And so they really do a lot of the, or do pretty much all the physician management in their particular markets. But once again, it really becomes a support role for us, and they become the conduit as we roll things out, as we standardize things to help us make sure those are initiated in the different markets. But it is a challenge. And so, when I talk about standardization, you can standardize to a point, but because of the differences that we just talked about, you really have to be able to be, agile and flexible, dependent on the market.
Let's talk about technology next. No doubt it has an impact on healthcare. I'd be curious to know your thoughts on how it's impacting healthcare today, and then is it possible that it could maybe negatively impact the practice of health at some point in some ways?
So technology's come a long way. And so it's given us a lot of advantages in patient care. The first one that usually comes to mind is robotics and surgery, where things are more precise, leading to faster recoveries, less painful recoveries, that kind of thing. And, I think that's one of the biggest things. And so many areas that there has been such advancements in technology. One thing is keeping up, because everybody wants the newest technology, the newest toy. And, as a system, you can't have all of them. There's got to be some rationalization around what makes sense, what's best for patient care. And so that becomes difficult, when you start trying to figure out what's applicable. Because, we as physicians think that, we need what we need for our patients, But at the end of the day, does it really make a difference in patient care or patient outcomes is really what we focus on. So even though it has advanced healthcare, I do think at times it makes it tough to take care of patients because you have so many different technologies that you can use.
Yeah, that is the counterintuitive aspect to it of technology. We know that patient communication is critical, we know it's difficult, particularly on the inpatient side of things. How are you trying to manage this on the inpatient and ambulatory side when you're dealing with patients and families and trying to provide care, do the clinical things which are necessary, but then also to keep the patients and their families informed of what's happening, what's the diagnosis and prognosis?
So admittedly, this is tough.
Right.
The patient communication part. I mean, we really struggled with this during COVID. When everybody was isolated, when families couldn't necessarily visit COVID units, it really became tough. And so we flipped a lot to virtual or telephonic. We've since kind of backed off of some of that. I think for us, it's making sure that we don't forget about that patient care relationship between nursing, physicians, APPs, and our other healthcare workers who help take care of the patient. That there's an open line of communication. Our nurses can get rid of or can get a hold of our physicians at any time. And so I think it's understanding the need to make sure that the patient and the family is informed, especially if a patient can't communicate. It's really important to determine who is the communicator for the patient, because it's tough to try to communicate sometimes with 8 or 10 family members. So I think we try to isolate who is the primary person for communication, what's the best way they want to communicate. And I think that's what we try to maximize. I think one thing that's actually helped in this area is over the years, the advent of hospitalist type groups that are in the hospital 24/7. And so if something comes up, usually there's somebody from that team who can actually step in and, and have a conversation or figure out what needs to happen from that standpoint. But it's tough. I mean, it's something that we have to work at regularly to make sure, because patients want to communicate in different ways. Take our older patients, for example. A lot of them don't have apps. Some of them don't even have cell phones. And so not just on the inpatient side, but even on the outpatient side, we've got things like MyChart, in Epic, that's the patient portal. And that works well for, a lot of our populations, but not for everybody. So I'll, just transparently say it's still a work in progress, to figure out what is that best way of communication. I mean, there's platforms, there's other ways that companies have to do it, but I don't think any of us have figured out, the perfect way to do it by any stretch of imagination.
You mentioned the patient portal, and that is great for the patient as the recipient of the information. Is it more of a burden on physicians in general when the patient or the families are asking follow-up questions through the portal, that someone, ultimately the physician, has to provide that information?
I don't know that it's more difficult. It's another avenue you have to check and look at, versus, face-to-face conversation, telephone conversation. Now, depending on how that, how it's done and what portal is used, I think it's now become just, we're used to it. Right. From that standpoint. Sometimes it's actually easier because you can take care of it, in the portal itself, which sometimes saves a phone call. Right. Having to figure out who to make that phone call to. So I think there are advantages. I don't know that there's a disadvantage, to be very frank, because it is a means to be able to communicate with a patient. I think it's just become, part of what we do in our patient communication now.
Switching to physician sentiment about their own careers, the COVID pandemic clearly had a huge impact on physicians and negatively impacted some physician satisfaction rates with their career. What are you doing as a leader? What's your team doing to address this?
So in my role, physician wellness and well-being, or provider wellness and well-being, actually rolls up to me. And so we had some programs in place prior to COVID. They actually got ramped up significantly in COVID. They're everything from coaching to group meetings, to basically lifestyle assistance, where we have programs that will help the physicians, if they need help, during their day with stuff. We have multiple programs. I think there's 5 in total that are offered. And so that was done during COVID. And then as we've come out of COVID, a lot of people are still struggling, because it really changed a lot about how we practice medicine, how we interact. We went to basically 100% virtual there for a while on the outside of the hospital. And even in the hospital, it was mostly virtual when you talk about the communication part of it, even though it was face to face with patients. It was tough. Everybody was masked, everybody was gowned up. So you didn't even hardly recognize people sometimes, when the mask went away, just because you hadn't seen faces in so long from that standpoint.
Right.
But we continue to have the wellness programs. We actually, this past summer, actually in the fall for Physician Suicide Awareness Day, we actually did a webinar to make sure that the applicable information was presented. We had a national expert come in and talk about physician wellness, and in particular around physician suicide. So it continues to be a focus of ours. We actually have gone back and just recently we'll set up a wellness committee to look across all of our ministries and all of our markets at what they're doing at a local market level. And, what can we learn from what they're doing locally? What can we help support from a system standpoint? So it still continues to remain a focus for us.
Yeah, it's important. It's important because we know that it's a difficult job on its best day, and certain things have made it tougher. Speaking of something that could make a job tougher for a physician, let's talk a little bit about the pros and cons of electronic medical records from a physician standpoint. We know in theory it's good for the patient, and we know it's good for the payers because a lot of electronic medical record systems are designed really to effectuate the payment. But it's very expensive for the hospitals, and it's also a tough training process for the physicians, particularly if they have to change over. Can you talk a little bit about that from a physician perspective primarily?
Sure. So, in the advent of medical records, in my career, having gone from all paper to electronic and multiple iterations, I think there are advantages that have come along with it. But at the same time, I think there are areas where electronic medical records have kind of cut into medical practice.
Right.
The big positive about electronic medical records is you have access to so much information at your fingertips. Now that we communicate in systems that where, with Epic, for example, different organizations are on Epic, the information feeds in, so you can access it if somebody's seen it in another hospital outside of your system if they have Epic. So there's advantages there, but unfortunately, I think it's cut into the art of medicine, and the art of medicine is sitting down talking to the patient. Because unfortunately, you get driven to more and more of the use of the medical record. Whereas before, we spent that time sitting, talking, and listening to patients. There's so many different boxes you have to check because they're available now. And a lot of this is payer driven from a standpoint of us to meet certain criteria. I think you have to be careful because there's that danger of treating and looking at the computer instead of the patient sitting in front of you. And I think that's the biggest piece of it. I was one of those who didn't take a computer in the room with me. I took a notepad. I pre-charted, I post-charted. But not everybody works that way. And I think others have found it challenging, when to determine, okay, when do I get away from the computer, get everything I need from the patient and then finish, everything in computer, because everything's done there. All your documentation, all your orders. I mean, there is no paper anymore, essentially.
Yeah, or for hospitals that have the resources, they use a scribe. So there's another person in the room that's inputting the information while you, the physician, are talking to the patient, which seems to be a big expense. But
it's very expensive. Plus, can tell you some patients don't want somebody else in the room.
right, yeah. What's their role?
Yeah, I mean, in our system, categorically, we don't use scribes. But at the end of the day, there are some systems that do. I have colleagues who've had scribes for years, but not all patients want somebody else in the room, when they're having that, confidential conversation.
Right.
Another shift in healthcare is the shift from volume-based to value-based care. What are your thoughts on the future in this shift?
So value-based care, I think, is definitely here to stay. It's been a shift in how we do things. But at the end of the day, I think we're finally getting better at it. And that, we're looking at, patient populations, we're looking at patients with, certain disease states, and how do we effectively treat them, categorically instead of, one-off. And I think now that we're looking at populations and understanding that we're managing populations and, where you have to be mindful of what we spend on patient care. I think it's actually a positive. I think it makes us step back and think about, do I really need to do this test? Does this patient really need an additional medication? So I think it's a positive. I do think across the country, we are getting better at it. Some organizations are very good at it. But it definitely is a change. And as you look at the volume shift, and especially as we see more volume going from inpatient to outpatient, we've got to be mindful of how we manage that volume and how we take care of those patients. I think it brings in the financial component, which historically hasn't been how we practice medicine. And I think, there's two sides of that. I mean, I think it was a long time overdue, so that we can, do our part to control healthcare costs. At the same time, I think, you just got to make sure that you're still doing the right thing for your patient and that the patient gets what they need from their standpoint.
Mm-hmm.
Right.
I guess you have to get that balance right in order to continue to exist in healthcare these days.
Will be. And it's going to be a transition for the physicians as they are measured on things that maybe haven't been points of measurement in the past. Quality metrics, et cetera, cost metrics.
Right. And the nice part about it, the reporting part of it continues to get better and better.
Right.
And so the scorecards that we have available to be able to look at the populations that we manage continue to get better, continue to get more detailed. And so that really keeps it in front of us so that we understand where we are, where we are in the patient care spectrum. We never knew that before. We didn't have a clue.
Right.
And I think that's one of the big advantages is the data piece of it is caught up, with really the theory of value-based care. And now that that's happened and you got the insight you need and you got the data you need, I think that's what's helping us get better and better at, at delivering value-based care.
Well, we've covered a lot of topics today. Dr. Marcus Blackstone, thank you so much for joining us. You are the Acute Care Chief Medical Officer, Bon Secours Mercy Health, and we are grateful for your time.
Thank you.
Thanks. I appreciate the opportunity.
For those of you who joined us today, we hope you enjoyed this conversation, learned a little bit more about the healthcare industry, and on behalf of Matthew and the whole team at Taking the Pulse, we look forward to seeing you next time right here on Taking the Pulse, a healthcare and life sciences video podcast.